Hi and welcome everyone. My name is Yasser Elsayed, and my presentation today is about care bundle of cardiovascular system in neonates. It's a comprehensive educational module on assessment of cardiovascular system, including systemic cardiovascular system and pulmonary circulation. I have nothing to disclose in this presentation. And I have four main objectives to discuss over the next 30 minutes. At the end of this presentation, the candidate will be able to first demonstrate the physiologic categories of compromised cardiovascular performance, including systemic and pulmonary performance. Second, demonstrate the clinical categories of hemodynamic instability. Third, differentiate the common neonatal diseases associated with hemodynamic instability. So we'll discuss the physiology, then the clinical categories, and the different diseases that might be associated with hemodynamic instability. And at the end, the objective number 4, how to select the appropriate logical support for the cardiovascular system. Before we start, let us discuss briefly the physiology of oxygen delivery. As you know, the main goal of the cardiovascular system is to maintain normal blood flow, and the normal blood flow is needed to maintain normal delivery of the oxygen at the tissue level. But we need 3 systems to maintain normal oxygen delivery. The respiratory system to maintain normal oxygen saturation, blood normal content of hemoglobin to maintain normal hemoglobin carrying capacity of oxygen, and then the cardiovascular system, which is responsible for maintaining normal blood flow or cardiac output. If any one of the 3 systems compromised, then the oxygen delivery will be decreased at the tissue level, which will be compensated immediately within a fraction of a second by autoregulation, which is a release of nitric oxide at the tissue level, which will induce hypoxic vasodilatation to increase the blood flow. If the autoregulation compromised, then the tissues will extract more oxygen from the venous compartment or from the oxygen left at the tissue level, left over. But if the extraction is at the maximum level, and there is no any more capacity to extract because of severe low oxygen delivery, then the aerobic metabolism will be converted to anaerobic metabolism with production of lactic acid, but that might be associated also with end organ dysfunction, because anaerobic metabolism is not the physiologic pathway to maintain or to continue the organ performance, normal organ performance. If you are working in any kind of intensive care, either neonatal intensive care, pediatric intensive care, or adult intensive care, and assess any admitted critically ill patient, the critical illness will be under one of the 2 main categories. Either it is related to high risk of hypoxemia due to lung-related issue with potentially low oxygen saturation, which could be related to limited diffusion through the alveolar membrane, intrapulmonary right left shunt, hypoventilation, pulmonary hypertension, pulmonary congestion, or VQ mismatch. So that's one of the main categories, and we'll discuss this category in details in the second part of the presentation when we discuss the compromised pulmonary circulation. Or the patient might be suffering from any issue might lead to hypoxia, and the hypoxia typically related to the systemic cardiovascular issue, which could be low preload, low systemic vascular resistance, high afterload, left-right shunt, which is a common issue in neonates or premature infants, or anemia. As you remember, These are the three main categories responsible for normal oxygen delivery: maintaining normal hemoglobin, normal blood flow, and normal arterial oxygen saturation through the respiratory system. Now we'll start with the systemic circulation, and systemic circulation can be again any issue related to low preload, low systemic vascular resistance, high afterload, or left-right shunt. Now let us focus on the most important presentation, or the most critical one, which is shock. And we have now etiological categories of shock to just make it easy to understand. Either functional cardiovascular shock. In this category, we have normal heart structure. We don't have any issue with the heart structure. It is just a functional issue. It could be related to septic shock, failure of postnatal transition in preterm infant due to sudden increase in the systemic vascular resistance in premature infants after birth, after separation or cutting or clamping the umbilical cord. Late onset shock in preterm infant, or it could be related to pulmonary hypertension, or could be related to hypoxic ischemic encephalopathy, or arrhythmia, or hypovolemia. All of these are functional cardiovascular issues or shock with assumed normal heart structure. But it could be related to structural shock or abnormal heart structure, like in coarctation or hypoplastic left heart syndrome, left-right shunt in PDA, AV malformation, arteriovenous malformation, cardiomyopathy like hypertrophic cardiomyopathy or restrictive dilated cardiomyopathy. Now let us discuss the physiologic categories of shock. Before we assess shock as a clinical entity, let us understand the physiologic categories. And each disease or each neonatal issue, like for example infection or sepsis, might be presented with more than one physiologic categories. So we have vasodilatory physiology with peripheral vasodilatation, vasoconstrictor physiology with high systemic vascular resistance, and we have also cardiogenic shock, we have hypovolemic shock, we have left-right shunt physiology, and we have obstructive shock, and at the end we have restrictive physiology. And let us discuss all of them in relation to the disease or the issue that might cause any one of these abnormal physiology. Now let us discuss objective number 3, the clinical presentation of shock. And with each clinical the clinical entity or issue that might happen in premature or term infant, we have one or more of the underlying expected physiology. So in preterm infant, early after birth, during early postnatal transition, we may have vasoconstrictor physiology, due to sudden increase in the systemic vascular resistance after birth, and the heart of premature infant might not tolerate that. Cardiogenic shock might also happen. Vasodilatory shock might happen as well. So each one of them should be treated differently with a different logical support. Left-right shunt physiology, although PDA usually presented later beyond the third day of life clinically, but the PDE might be significant and might be presented during early postnatal transition. Hypovolemia, although it is not the most common type of shock in premature infant, unless you have any underlying cause of volume losses. Premature, late, beyond the postnatal transition, vasodilatory physiology might be the most common physiology, left-right shunt physiology, hypovolemic physiology as well. In septic shock, vasodilatory physiology is the most common. Hypovolemia due to third space losses, vasoconstrictor physiology, although it is more common in older ages, or pediatric septic shock. HIE, we may expect cardiogenic shock, vasoconstrictor physiology, secondary to cooling or hypothermia. Vasodilatory shock might happen, hypovolemia as well. Infant of diabetic mother with hypertrophy, we may expect hypovolemic shock, and in this situation it's contraindicated to give any kind of inotropes. In pulmonary hypertension, we may expect vasodilator physiology, cardiogenic shock, vasoconstrictor physiology, hypovolemic physiology, and in post-shunt closure, like post-VD ligation or post-AV malformation embolization, we may expect vasoconstrictor physiology. That's why we are using Merinon as a common medication to be used in this category, or dobutamine if you don't have Merinon, together with IV fluids under assessment or serial echocardiography, hypovolemic shock or the cardiogenic shock in late stages. In LV hypoplasia, you may expect obstructive shock, or restrictive physiology in LV hypoplasia, left ventricle hypoplasia, because there is limited space for fluid or blood in this category. Pericardial tamponade, we may expect restrictive physiology. In tachyarrhythmia, in later stages of tachyarrhythmia, for example, we may expect hypovolemia because of the tachycardia. There is limited time or less time for heart filling, and cardiogenic shock in late stages of tachyarrhythmia, like supraventricular tachycardia. Bradyarrhythmia, due to severe bradycardia, if the heart rate less than 60 beats per minute, we may expect cardiogenic shock because of the decreased cardiac output. Because of the, as you know, cardiac output is equal heart rate multiplied by stroke volume. And just to keep in mind, very, very important to remember that the overlap physiology is common. So you may have more than one physiology under the same disease category. Now we have to use the cardiovascular medications according to the underlying physiology. Not to use the medications in an empiric fashion, like the same way of management for everyone. Fluids, dopamine, dobutamine, for any disease. We have to use a medication according to the underlying physiology. So we have the first category. We have 5 total categories. Vasopressors. We have vasopressin, norepinephrine. It makes sense to be used in vasodilatory physiology. We have inotropous vasopressor effect that might be used with any infant with cardiogenic shock. Also vasodilatory physiology, but you need higher doses of dopamine or epinephrine for vasodilatory physiology. So it makes sense to use the vasopressors as a first line. We have inotropous vasodilator effect like dobutamine, Merinon. Merinon is long-acting medication with peripheral vasodilation effect. It's better to be used by someone expert in hemodynamics or under guidance of functional echocardiography. They can be used in vasoconstrictor physiology and also in cardiogenic shock. Fluids. Fluid should be considered as a medication that should be used only if indicated. If there is evidence of hypovolemia either by echo or by clinical presentation, then we can use fluids. Steroids in case of refractory shock. Refractory shock might be related to suprarenal dysfunction, like in premature infants or with HIE. So keep steroids in your mind if you are escalating the dose and there is no enough response. Dopamine is not the preferred medication to be used, especially in higher doses, even in adult, because of a lot of side effects related to increased oxygen consumption by the heart. It might affect the brain development. It might also affect the pulmonary circulation. It might increase the pulmonary vascular resistance. So if there is any risk of pulmonary hypertension, dopamine might worsen the pulmonary vascular resistance. So you may use it, but we now recommend not to use or exceed a dose of 10 mics per kg per minute. Then we have some atypical scenarios. and the typical common scenarios that you might need to keep in mind. Term infant discharged from the well baby unit, then presented to the ER at day 5 with poor perfusion, poor peripheral pulses, and metabolic acidosis. And the ER physician started antibiotics plus Septicor cup, and you came to the ER as he contacted you for in ICU admission, and you were able to hear a murmur. With the CRP came 6, which is not high, and unremarkable CBC. If I ask you what was the most important one step or one intervention that you need to do in this case, the answer should be start the prostaglandin and call pediatric cardiology. In this situation, it could be a presentation of hypoplastic left heart syndrome or significant coarctation. Even if you start the prostaglandin and the evaluation by echo revealed that there is no significant coarctation or cardiac issues, no problem. You can stop the prostaglandin, but it is life-saving in this situation. Another atypical scenario, when you have term infant with a diabetic mother admitted with hypoglycemia and they develop oliguria with narrow pulse pressure. And narrow pulse pressure might be because of low cardiac output. If you don't have an echo, what would be the most important intervention in this case? Fluids, and only fluids, full stop. Boluses of fluids, and it is really dangerous to give any troops in this case because it might worsen filling of the heart. Another case scenario, we have term infant admitted to NICU with HIE on cardiovascular medications for hypotension. The team kept increasing the cardiovascular support with continued worsening until they reached dopamine of 20 mics per kg per minute, dobutamine of 15 mics per kg per minute, and epinephrine of 1 mic. Epinephrine of 1 mic is really high dose. It's almost equivalent to 100 mics per kg per minute of dopamine. What would be the most important intervention if you don't have echocardiography in this case? Very common to happen, especially if you don't have echo. You keep increasing the medication and adding medication over medication, and the case might worsen only because of the medications, not because of the original cardiovascular issue. So you need to stop all of the inotropes and give fluids. If you need to support the blood pressure because of hypotension, vasopressor like norepinephrine might be helpful in this case. And I will explain why you need to give fluids in this situation. Just to keep in mind that all of these medications, like dopamine, dobutamine, they have short half-life. Even if you need to start again the medication, it's not a problem. Within a few minutes, you will get the medication working with the circulation without any problem. So this is a real scenario happened in our unit long time ago. As you can see, the for chamber review, in this case, empty heart. There is no blood, significant amount of blood detected in the heart with false hypertrophy just because of the medications. So the cardiovascular medications might increase the systolic performance on expense of diastolic filling of the heart. So you may get significant worsening of the diastolic performance because of these medications. What you need to do is just to stop the medications. And this is echocardiography for the same infant just 24 hours after we stop the medication. Everything is back to normal performance, filling of the heart. And this infant was just giving fluids after we stopped all of the unnecessary medications. If you have unresponsiveness to any cardiovascular medication, keep in mind it could be wrong medication, so you need to reassess the physiologic logical support for this infant. It could be high dose of inotropes. You need to wean and watch for improvement or even stop the medications. It could be suprarenal dysfunction, so you may need to consider steroids. It could be missed cardiopathology. So if you haven't done that yet, call pediatric cardiologist to do echocardiography and assess for any missed cardiac pathology. If you would like to read the details about our approach, you have the article, our published article about the physiologic-based integrated algorithm in the management of neonatal hemodynamic instability for more details. Now let us discuss the second part of the cardiovascular system. The pulmonary circulation, or the respiratory related combined with cardiovascular related hypoxemia. So it could be hypoxemia, it could be respiratory related or cardiovascular related. As you can see here, it could be related to limited diffusion, right to left shunt, intrapulmonary or intracardiac right to left shunt, hypoventilation, pulmonary congestion, pulmonary hypertension, or VQ mismatch. We have in this slide types of pulmonary hypertension in neonates. And pulmonary hypertension is not only increase in pulmonary vascular resistance, it might be either increase in resistance or increase in the blood flow. Both can cause significant pulmonary hypertension, and the management is different. So we have the first three types here: hypoxic vasoconstriction, which is typical pulmonary hypertension like PPHN, or abnormal vasoconstriction due to premature closure of the PDA in utero, or pulmonary vascular hypoplasia like in congenital diaphragmatic hernia. The first three types are associated with increased pulmonary vascular resistance, and we may consider to use pulmonary vasodilator like nitric oxide in all of these etiologies. But we may have number 4 and 5, the pulmonary hypertension associated with high pulmonary blood flow. And high pulmonary blood flow might be congenital with left-right shunt, and typically the preterm infant with left-right shunt through the PDA is one example of that, or could be pulmonary venous hypertension, not arterial hypertension, which is more difficult to manage and more difficult to diagnose, like in congenital heart defects related to left atrial hypertension, mitral valve disease, or aortic valve disease. So you have more stagnation of the blood at the pulmonary venous circulation. It might be also associated with obstructive anomalous pulmonary venous drainage. Here, it is contraindicated to give pulmonary vasodilators. We need to limit the shunt. We need to limit the blood flow to the lung to decrease the worsening ventilation perfusion mismatch. So we have three categories or three types of diseases with increased pulmonary vascular resistance, and two types with increased pulmonary circulation or blood flow or VQ mismatch. We have this atypical scenario: term infant in well baby unit, stable apart from mild desaturations, on and off desaturations, and mild tachypnea. To differentiate lung-related desaturation from pulmonary hypertension, you need to keep in mind two things. The differential oxygenation, the difference between pre and post-ductal saturations, more than 5 is really significant, more than 5 difference in saturation, or if you have more than 2 desaturations within 2 hours. And I'm talking about term infant because this mechanism does not apply to preterm infant. That might be considered acceptable in preterm infants. If you have any 1 or even 2, then you have to investigate for pulmonary hypertension. And here, simply, if you don't have the ability to do lung ultrasound, which is now the first modality to assess lung parenchyma in our unit, you can use both chest X-ray and the blood gases, and that might give you a very good clue related to the underlying pathophysiology. So in PPHN, you as you have in this X-ray, oligemic lung and clear lung parenchyma, but you might have also frequent desaturations or increased oxygen requirement not related to parenchymal lung disease, with normal blood gases or mild metabolic acidosis. In the respiratory distress syndrome, you may have acute lung injury due to surfactant deficiency. As you can see in the X-ray, you have volume loss of the lung. It might be associated with respiratory acidosis or hypoxemia. Meconium aspiration, it might be more severe. You may have surfactant inactivation with the pneumonitis and respiratory acidosis with hypoxemia. And both can be presented clinically and also in the blood gases. Transient tachypnea of newborn, you can have X-ray with well-inflated lung, but with streaks of fluids in the lung due to interstitial fluid collection or in the fissures, with mild hypoxemia and mild respiratory acidosis. And then you may have pneumonia, like patchy pneumonia due to congenital pneumonia, or congenital viral pneumonia with patchy infiltrates, hypoxemia, and it might be associated with some systemic manifestations like systemic shock or hypotension in this case, and with variable degree of clinical severity. Pulmonary hypertension, you need to confirm the diagnosis by echocardiography. And as you can see here in this four-chamber view, you have significant dilatation of the right side of the heart compared to the left side with the tricuspid regurg. And this is before use of inhaled nitric oxide or any pulmonary vasodilator that you have in your unit. And after nitric oxide, I think you can detect significant improvement of the heart performance, and there is no significant dilatation of the right side anymore, and even the shunt through the ASD now is left-right, signifying higher pressure on the left side compared to the right side. The previous straightforward example is related to an infant responsive to inhaled nitric oxide or responsive to pulmonary vasodilator. But if you have someone or a patient not responsive to pulmonary vasodilator, you may consider this algorithm. In this algorithm, you may consider, as I mentioned, the pulmonary vasodilators at the beginning. If there is good response, it's fine, just watch by echo and clinically. But if there is no good response and the oxygen requirement is still high and the pulmonary hypertension is still significant by echo, then you may need to assess the underlying pathophysiology of unresponsiveness. Is it related to low preload? You may need to give fluids. If it is related to RV dysfunction, you may need to assess the blood pressure also. If the blood pressure is normal, there is no hypotension, you may use Merinon or dobutamine. But if there is associated hypotension or vasodilatory physiology, then use vasopressors instead. And in this situation, you may use norepinephrine or vasopressin. And it's better to avoid dopamine, because dopamine might increase the pulmonary vascular resistance, and the same might happen with epinephrine. And reassess by echocardiography and clinically. If the case improved, it's very good. If there is no adequate improvement and still RV dysfunction with the low cardiac output, in this situation we may use prostaglandin to open the duct to relieve the pressure, the high afterload on the right ventricle. And if there is no response, then we might need to repeat the echocardiography by another expert person to be sure that there is no underlying other cardiac pathology. And the most tricky and important one to rule out is anomalous pulmonary venous return. In this situation, or some situations, might be difficult to diagnose by echo, and you might need to do CT angio. And then at the end, ECMO might be needed in very unresponsive or significant cases, unresponsive to any kind of support for systemic and pulmonary circulation. So for conclusion, you need to look at the trend of systolic, diastolic, and pulse pressure. You need to also assess all of other parameters related to hemodynamic instability before and after any deterioration or intervention. Compare the values to the normalized centile curves for premature infant. Integrate blood pressure values with other parameters like urine output acidosis, mean airway pressure, fluid status, hemoglobin, oxygen requirement, and peripheral perfusion. Change your formulated recommendation if there is no improvement or with worsening after any intervention. Dopamine has a remarkable side effects, and it is not recommended as a first line anymore. Thank you very much.